This
So,
conference will now be
There you go.
recorded.
perfect. Okay.
You
All right.
might just double tap it or something, Michelle.
Okay.
Okay. So welcome everyone. Let's hope we have some more people join us, but if not, well, I'll just have to be entertaining ourselves. So Kenny, you missed in that we have two other CLL patients here.
Okay.
Tom Henry, Tom, are you from Florida? Do you live in Florida?
I live in Tampa.
Oh, Tampa.
And are you working
Oh.
right now? During all this, I know you're a pharmacist, but you work as well as a pharmacist, I know.
My last full-time assignment was in August. And so I've been doing mostly work from home consulting type work since August, which has perfectly played in, to this situation. So, yeah, fortunately, I don't have to go to work every day and be exposed to, potentially people that have the COVID virus.
Thank goodness. I was wondering about you when I heard you last week speaking. So, and Kenny J. Blatt also has CLL. Hey, I outnumber you this time.
I see that.
Myeloma against me. So now, thank you, gentlemen, Jay and Tom.
Well, that's actually probably more in line with the norm anyways, isn't it? Aren't there more leukemia patients than myeloma patients?
Well, CLL is the #1 adult blood cancer.
Right.
So I think that you would see that.
And I think myeloma is number 3.
Something in that range, I think.
So,
Somebody explain to me what myeloma is exactly?
I'm sorry?
Can you explain to me what your disease is exactly?
Oh, sure. Sure. So,
Michelle.
Yeah, Kenny and Richard can answer that on multiple myeloma. Sorry.
Sure. Richard, you mind if I take off and start?
Go right ahead, Ken.
Okay. So, so multiple myeloma, just like leukemia and lymphoma and so forth, is a blood cancer, and it tends to, it has multiple side effects, and sometimes can have different versions leading up to it, which can be asymptomatic. And really, one of the markers of when they determine that you are considered to have myeloma is not just to have the proteins, the myeloma proteins in your blood, but also when you have certain symptoms. And one of the big ones is a bone involvement, so bone lesions. And so what happens is that the cancer itself shuts down your osteoblasts, which is the enzyme that creates new bone for you. You have two basic ones. Not to sound like a smart aleck, but I've been asked this a lot. And so the osteoclasts, which are what take away old bone, actually keep going. And so what that does, of course, is that they're not taking away old bone, they're taking away good bone, and there's not building new bone. And so what ends up happening very often is that you have fractures and lesions, and typically, of course, as you can imagine, they would start very often in small bones, such as in your spine, your collarbones, your clavicle, sternum. That's ribs, of course, and your spine is a big one. I actually have 2 compression fractures in the middle of my back. My scapulas look like chewed dog ears, is what the MRIs look like. I've got a large hole in my hip, actually, in my left hip, which was interesting. There's neither rhyme nor reason. I have a good friend who used to be on the board of the organization I run. She has myeloma. She found out that she had myeloma because she was walking her dog. I think she was 49 at the time, and she was walking her dog, and it just pulled hard. Just a big Labrador or something. It pulled hard, and she broke her arm right in the middle, right here, in the middle of her arm. And when they couldn't figure out why, they thought that was a little bit odd. So when they went and did an MRI, they noticed that she had a lesion here, and then they did, and here, one on the opposite arm. It's just sort of bizarre. And that, of course, that led to blood tests, and it led to determining that she did have multiple myeloma. There are other complications that come from it, because organ involvement does typically get into. So they monitor our kidney function and our liver function, because those things come into play also. There also are calcium levels, because sometimes there's actually too much, interesting, calcium that winds up there. And actually, Richard,
Excuse me, Ken, is it something that they can control? I mean, is it considered a slow growing disease? And can
it's across the board. It's actually across the board. So it can be aggressive. And I've heard it listed. I don't know how official these terms are, but I've heard it as aggressive, moderately aggressive, or mildly aggressive. Which means that it is progressing, typically does progress, but it varies. And so the initial answer is yes. Is it something they can control? Sure, absolutely. There are some people and some versions of it. I have probably what's the most common of what they consider the more aggressive myelomas, the IgG kappa. I don't know if that's what you have, Richard, but that.
Yeah.
They look at your free light chains
Yeah.
in order to determine
Quite
right.
carefully.
So, right. Yeah.
Yeah. Jay and Tom, I think I'd say that it's been 5.5, starting to close on 6 years for me. When I was first diagnosed, the average was 5 years, the average lifespan. There is no at present cure for multiple myeloma, except when you close your eyes and die. There is, but to put that into context, 5 years ago, there were exactly 100 clinical trials that were officially being conducted with myeloma cells. And today, there are more than 1,000. So it's finally caught the interest of the scientific community, so that we can take a look at kind of what's happening, and there's some emphasis upon trying to find some cures, because no one likes cancer without a cure. For me, 5.5 years ago, it struck my spine. I lost 5 inches in height. So it's very amusing to have pictures of me with my family. And, I'm about the same height as some of my grandchildren, and 50 pounds. So I was 5'10", and about 180 pounds or 85 pounds or whatever. And it really devastated me, and obviously had to retire and resign from my job. We monitor very carefully the chemical data that's collected on me every month, and the light chains. And I'm not sure whether I fully understand that, but is the key monitoring blood condition. And for me, it has started to turn upwards. And what my oncologist said to me, in fact, just yesterday, is that we're going to change my medication routine, and I will go from a couple of pills daily to an injection weekly. And I couldn't even begin to tell you what the what the drugs are, but injection weekly, and then followed by a couple of pills. So they're starting to get concerned that it's maybe making a move towards a different status for me at this point. So a little bit of concern, but not surprised after 5.5 years. And I'm going to block on his name. Kenny, you might know, who was the media person who's
Tom
wrote
Brokaw.
Tom Brokaw.
Yep.
And Tom has 18, 19 years with multiple myeloma, I think. No, not that many.
No, actually, he just got diagnosed in, I want to say it was let me think about this. It was 2013.
Okay, okay,
Yeah, it was 2013, 2014. It was like
okay,
the year before I was
yeah, okay,
diagnosed.
yeah,
Yeah.
yeah, so,
Yeah.
and
And he
I
was super
broke,
healthy, 72, I
sure,
think, at the time.
yeah, yeah,
He was biking. In fact, he was biking down in South America somewhere with his
okay.
family, and he thought he had pulled something
Mhm.
in his back, and that's where a lot of people seem to get some sort of symptom from, is their back.
Yeah.
And that's what sort of started for him. And he went through the whole Mayo thing, did the bone
Yep,
marrow
yep,
transplant. So
yep,
you know,
yep.
hey, I'd like to hear about CLL. So I mean, so guys, how long have y'all had it? Jay, how long have you had?
Well, it's kind of hard to know for sure. In 2008, I had swollen lymph nodes and I had very low platelets. When I say very low, if normal platelet value would be 142,
Mhm.
in 2008, I was probably at about 125. And so I went for many years. My platelets were low, so they couldn't figure it out. My doctor said, you're healthy as a horse. We don't know what this is. We think you might have ITP. And, that's a platelet disorder. And they thought it was my immune system attacking my platelets. And, I didn't really want to hear it. So I said, okay, great, ITP, I'll see you in 10 years. So I
Right.
went and did my thing. And by 2016, I was actually November of 2015, I was surf casting on a jetty. And I bent down and I had a pain in my thigh. And I said, that's nothing. And, I fished through it for a couple hours, went home, and I had a blood clot in my thigh, like the size of Texas. So at that point, I'm thinking, okay, this isn't good. And we went and they did some testing. And my general practitioner said, I don't think you have ITP. I think you have something else. We're going to make you go to a hematologist and see what's going on. So we went, and then I was diagnosed with CLL in January of 2016. So I've been very fortunate in that chalk it up to luck, chalk it up to my choice of lifestyle, which is a very healthy one. My absolute lymphocyte count at diagnosis, and that's the one they use, basically to determine where you're at as far as aggressiveness of the disease. Mine was 10.4 at diagnosis, and just 2 weeks ago it was 9.6. So, I mean, not 2 weeks ago, about 2 months ago, it was 9.6. So I've been very fortunate. But, and my platelets, I figured out a way. Some of us, if we have a mild form of CLL, things like diet and exercise and supplementing can absolutely have an impact on, for certain people, not everybody, but some people seem to track that way. And I'm fortunate, I'm one of those. So my platelets, after 10, I'd say 8 years of going down, stabilized once I switched to something called a macrobiotic diet. Once I did that, my platelets immediately went from about 113 to 172. Then it stabilized because while I was doing great with my platelets, I wasn't doing so great with my white blood cells. So I experimented, and I've been fortunate. And since no one is doing a peer-reviewed study on me, I can only go by, anecdotal experience, my own experience. And my white blood cells have basically, the highest they've ever gone, knock wood, has been 21.7, and now they're 9.6. So I'm not complaining. I do not have platelet symptoms, and if you have bad platelets, you could be bleeding a lot, you could be getting blood clots, you could be getting, I never say the word right, what is it, petechiae, Michelle? The doc?
Petechia, or Tom, you probably know that, right?
I'm sorry, what was it?
What do you call the dot that a lot of CLLers get from having poor functioning platelets.
Oh, yeah.
PTA,
I know
Petechiae,
what you're talking about. I've heard of it.
yeah.
yeah,
red-
Doc.
That's petechiae.
I
Yeah,
think that's right.
good, thank you. So anyway, so I don't get those anymore. I don't bleed anymore. I was getting bloody noses. So I've been fortunate. For some of us,
Are you saying that's mostly from your diet?
absolutely. And
Really?
there's not even a question in that, not me saying this, but doctors that I speak to, and there's an association for people that have ITP, and it's called the Platelet Disorders Support Association. And they recommend that you can eat certain foods if your spleen is still working and not blocking the platelets, and your bone marrow isn't totally blocking your ability to make platelets because it's overwhelmed by white blood cells. Yes, diet, exercise, that kind of thing impacts platelets. Okay. Now, will diet and exercise impact red blood cells? I think so, because if you're walking and doing exercise, aerobic type exercise, what happens is, especially if you're walking or jogging, you're giving a signal to your body that says, I need more oxygen to provide to the tissue. And so my hemoglobin has remained normal for the last 4 years. My red blood cells are just a tad below normal. And I've been very, very fortunate. All the things that are generally bad things, I've managed to so far hang in there with. But again, I have a certain type of CLL that is moderately aggressive, or could be. And I have something called trisomy 12. And then I have some other weird thing that nobody even knows what the heck it does. And it's, Tom's going to know what this is. It's a gene translocation. Does that sound right? And it's on 1418. And less than half of 1% of anyone with CLL has this wacky thing. So a specialist said to me, this is either helping you or it's going to hurt you. It looks like it's helping me. So that's my story. You know, at least 52 months into the official diagnosis, no complaints. I feel great. I'm 66 years old. I walk or jog 3 miles every day, and I eat a really great diet, and I avoid things that can mess with my, my blood values.
I love hearing that. That's awesome. So, and I'd love to talk to you more about what your diet and exercise regimen is later. The organization that I actually run it's called Throwing Bones, and our mission is to encourage all blood cancer patients and to help them and educate them to stay healthy and active through treatment, and the values associated with that. So some of our projects are relating to diet, nutrition, as well as your fitness routine. And you take people where you are.
Kenny, that's so terrific to hear.
Thanks.
Because very often people get ill, they get cancer, and they curl up into a little ball and they do nothing. And all of us here know you can't allow that to happen, because that's when you lose the battle. You have to battle on, and it's great. I mean, I see one of the most terrific CLL specialists in the world, a medical guy, but also, I always say this, as patients, we have to do the heavy lifting. If we don't take care of ourselves, if we just think, okay, I'm going to depend on a miracle drug, it's not enough.
Not going to be there.
Well, and that's right. And you know what? I think you're obviously a strong willed person by nature, I could tell. But I think that one of the challenges that a lot of patients have is that they're really used to, or at least they've conditioned themselves or been conditioned to accept whatever it is that their healthcare provider is that tells them. And sometimes they misinterpret it. I feel confident of that because I've heard many, many times over the past few years where some patient says, sure, that's great for you, but my doctor told me to take it easy, or I'm in pain, so I can't do that. And my first response is, I feel confident your doctor didn't tell you to sit on the couch and not do anything. I feel really confident that that's not what he told you, he or she. I mean, that's not true. And he didn't tell you to sit there and eat comfort food. Now I get that you're upset, and a lot of our response is to bring out the comfort food to make us feel good. And there's nothing wrong with that, but you got to balance that sort of thing, just like anybody else in the world, for sure. But when you're dealing with a diagnosis, whether it's cancer or not, but certainly when you're dealing with a diagnosis that affects your overall body, and there's pain involved, and limitation on physical mobility, it's even more important to actually do it. It's just the opposite of what they're telling you, as that I can't move. You have to move. You have to move.
Yeah, I think Jay and I can both attest to the fact that we're in a couple of Facebook CLL support groups, and we hear a lot of the patients that are being treated for CLL say, that they're plagued with extreme fatigue, for example, and a lot of their doctors will just ignore that and say that that's just not part of being CLL. And while it's counterintuitive, I found that if I get out and exercise, I feel better. I'm less tired. And so it's become a routine part of my, regimen of how I care for myself. So,
I get it.
I think Jay, Michelle, and myself are all advocates within our disease that if at all possible, you should at least once a year see a CLL specialist, even if that means jumping in the car and driving 6-8 hours, and having that CLL specialist coordinate with a doc back in your home area. But those people seem to be a little more receptive to some of the things that we talk about things like fatigue and, pain. There's a lot of people that say there should be no pain associated with CLL. And that's, we know that's not right, and it's like, first of all, if you got swollen lymph nodes and it's pressing on another organ, there's going to be pain. So,
right. I'm actually pointing to people on the screen as if y'all can see me. But see me pointing. You're absolutely right. And the hardest part is taking that first step. Sometimes, I mean that every morning. Sometimes when I get into like my third week of my round of chemo, I'm tired. I don't want to get up in the morning. And once I start moving, then entropy kicks in, and I'm cool. But it's just getting started. Of course, also I think we're dealing with 5 people who are really good self-advocates. So, and we can at least be as objective as we can be. I can tell. And we will ask questions, and that's challenging too. And I think that's part of at least what our mission is to encourage patients to ask questions, to be self-advocates. It's you're not being insensitive or disingenuous or mean-spirited by asking your oncologist what it is that you really should be doing.
So one of the things that I'm interested in hearing from the multiple myeloma patients is, I think one of the things about CLL that's really, a lot of people don't understand is it's a very heterogeneous disease. And so we have people that have, different gene mutations that affect their longevity and the course of treatment. For myself, Jay's been, diagnosed 12 years and is not on treatment. I was started on treatment 6 months after diagnosis, and my CLL was diagnosed during a routine physical exam with my general practitioner. Elevated lymphocyte count or white blood cell count, and it had only been a year since my previous exam, and that those lab values were normal. So, we do hear about people that, hadn't been to a doctor in 5, 6, 7, 8 years, and now all of a sudden have CLL. That wasn't the case with me. So, so there's a lot of, variability. We have a local CLL Society support, sponsored support group here in Tampa. One of the members of that group has been on watch and wait for 20 years. And just went on treatment on a clinical trial about 2 or 3 months ago. So there, it's not unheard of for people to not require any treatment at all, and it can be fairly well managed with just observing and routine blood tests on whatever the basis is. I was blessed in that, even though I have a more aggressive form of CLL and that it did require treatment, I never had any symptomology. So the only reason that I had to be treated is that, as Jay was alluding to, his platelets had dropped to like 125, mine dropped to 65. So the normal range is, and it depends on the lab, but it can be anywhere from like 140, 150 up to about 400. So, as I say, I went down to 65. My hemoglobin had dropped, to below 10. And so essentially what was happening was my cancer cells were crowding out the bone marrow, and I couldn't produce the normal cells that I needed to produce. And so that's what I went on. But, I've never had night sweats. I never had, lymph nodes that I could feel. And it was I just read an article a couple of days ago where I found something that patients with the 11q mutation are very prone to having very enlarged lymph nodes in their abdominal area that they don't even see unless they go for a CAT scan. And more we're discouraging people from having, imaging because of the radiology, risks of that imaging. So, they may not even be aware. So it's a very different disease. But what I wanted to hear from the myeloma patients is there a lot of variability in patients? And do you have patients that go for years and years and years and never need treatment?
Yeah, absolutely. I mean, and like I mentioned before, there's a smoldering myeloma. Well, there's actually what's the oh shoot, I just forgot the name of it. What's the one right before smoldering myeloma, Richard?
Yeah, it's smoldering.
No, but there's one before that. There's one before smoldering. It's which completely there's not even, they won't do anything, and it'll come to me later. Anyways, but there's like two levels before they say full blown myeloma, and like I said, the symptoms are what actually bump you into, when you become symptomatic. That's what bumps you into full blown myeloma at that point. So yes, there are different versions, and like I said, there are different types of myeloma a little bit. I honestly don't know them very well myself. I know that I have what's considered the more common of the more aggressive ones. It's IgG kappa, but it is controllable actually, and actually more controllable now than it even was, 6 years ago when I was diagnosed. So it's changed rapidly. And the the chemo that a lot of us were on that was infusions 4 or 5 years ago now are in pill form, or they'll do an IV push in there. I know I think Darzalex is coming out with, they've proposed an IV push for that. That's supposedly coming out soon, like in your belly or something like that. It's one of those subcutaneous. So they're having a sub-Q version of just about everything, which changes things a lot when you go from long, insane infusions that take up half your day to maybe a 45-minute subcutaneous IV push. It changes your world. And I think a common, Richard, did you have a transplant? Did you do a bone marrow transplant also?
No, I did stem cell.
Yeah, right. Yeah, so I did too.
Stem cell. Yep.
Yeah. So
And
that's a pretty common treatment.
Yeah, I mean it in their language, at Dana-Farber, it failed.
Right.
It did bring down some of the numbers and quite significantly, but it didn't push me into remission, which is what they were hoping for.
Me either. Yeah, it didn't do it for me either. But I got close, but no cigar. And then mine came back. I mean, like it didn't go away entirely, and then it kind of zoomed back 6 months later. So
I have a question. How common is your disease, and what does it go by? MLL, or what's the
MM is usually what you see. Yeah, MM.
So how common is ML? Because CLL is an orphan disease.
Mm-hmm.
Yeah, it's a rare disease.
It's very few people have it compared to other cancers, really.
So there's an estimated, and I know that they group leukemias together largely, which makes the pool seem a lot bigger, I'm guessing. But myeloma, they're estimated about 32,000 new cases in the United States this year. And I believe that I believe leukemia might be around 65, 70 as a whole, and I don't think they break it down. I think it's just
Ours is
leukemia.
22,000 approximately. Although what's last year, I want to say 20,800.
Just for CLL, you mean? Yeah. And then lymphoma, I think it's close to 80. Lymphoma. Now, granted, and what's the average? Is there an average age at diagnosis for CLL?
I've
Yes.
heard 70, but
What is it?
somewhere between 65 and 70 is what.
So it's
Yeah.
quite a bit older
Male.
than the multiple myeloma, which is much younger than that.
Not much. No,
Yeah.
multiple myeloma's average is 64.
Is it really, Rick? Or Kenny? Yep. Okay.
Yep. Yeah,
That's quite
64.
But we're seeing a lot of younger people, 30s and 40s, that are coming into the Facebook support groups that we have, and so I mean, they potentially are, going to deal with this for a much longer period of time than I will, and at this point, we're kind of considering, do we treat patients that are that young differently than we treat an older patient? And, so we have, we used to be a chemo-based treatment plan before there were these targeted therapies, the oral drugs. And now we're moving more and more to the oral targeted agents. And, but there's still some physicians that believe that, there is a place for, immunotherapy in that patient that's under 50 fit, and to try to buy them basically 8 to 10 year remission, where they don't have to be on drug and they just get followed. So
Sure. Michelle, how long have you actually had it?
I was diagnosed in 2012, mid 2012, but I think I had it before. And the average amount of time to treatment, but this is an average, because look at Jay and look at Tom, and I'm in the middle basically. But from the time I was diagnosed, it was about 3.5 years. And that is the average about to treatment. But I do believe I had it for some, when I think of certain things that had happened, I think I had it for quite a while, because unlike what people were saying, I was extremely fatigued, but extremely active. But that was a sign. I also wasn't sleeping because of my job. I got 2 to 4 hours sleep a night, 7 days a week. So I always figured it was that. And I did have horrible night sweats, which everyone said were hot flashes because I'm female. And I knew it was like around the clock though. So I did have those. Tom, it's interesting what you were saying, and that so with me, I have the 11q deletion and I'm IGHV unmutated, which unmutated you think is better, but it's not for CLL. But I was very interested in what you said about the swollen lymph nodes in 11q, because I had very visible swollen lymph nodes for probably about 7 months before I got treated. And also internally once they did a CAT scan. And my bone marrow, do you guys get bone marrow biopsies? Everybody here gotten one?
So I've had.
Multiple.
Oh, they're so fun, huh? So I was 91% infiltrated, my bone marrow. But Tom, it sounds like yours was pretty infiltrated too.
So I was about 70% infiltrated at the time of diagnosis. And, as we talk about self-advocating, more and more information coming out about very positive results between the combination of ibrutinib, which was the first drug that I started on, when it's given with venetoclax. So I went to my specialist and I said, I'm reading the data that says 75% of patients at 2 years have undetectable MRD, and I'd like to give it a shot. And he said, well, it's not an approved drug. We need to insurance will cover it. And I'm a 39-year Air Force Reserve veteran, so I'm retired military and I have TRICARE. And so he put in a prescription for it for prior authorization, and it came back the same day, approved. So
Wow, that's wow. The VA did that. Ooh.
no, it's
Oh, it's TRICARE for yeah. So you stayed away from the VA. It would have been a 6-month process for VA.
Yeah, we have one of the guys in our local support group that's a Agent Orange CLLer, and that's one, that's one of the only known causes of CLL.
Right.
And he's a VA patient, and so, but no, TRICARE, I go to the local cancer center here, which is like 3 miles from my house, which is a real piece of cake. And
so with mine, I went on a clinical trial, which actually originated at Dana-Farber, but it was national. And I really wanted to be on a clinical trial. It was a phase 2. I thought I wanted to be on one, but I was on the IFCR trial, which is ibrutinib and FCR. And ibrutinib had just a few weeks before been approved on frontline treatment, but it hadn't been one until then. So I had the combination of the two. I really do regret I had FCR due to what has been coming out now about it doesn't necessarily work so well for, I believe, is it 11q or is it the end? Yeah. So, and it can cause secondary cancers, but I stayed on ibrutinib until a few months ago. So I was on ibrutinib for almost 4 years every day. Kenny, I'm curious, our ibrutinib is a BTK inhibitor. Is that, Are you thinking like that or?
Sort of. So what I'm actually on, which is the granddaddy of myeloma drugs, I'm actually on a maintenance course of Revlimid. Which most myeloma patients will start with, or at least have previously. There's lots of initial first tier stuff now that have come out. That was pretty much the first tier 1 drug when I first started. It was the magic cocktail of dexamethasone, Revlimid, and Velcade. So I don't know if any of y'all are familiar with the dexamethasone, the steroid. Holy smokes, that's just brutal. Well,
there are some patients with CLL that have been treated with Revlimid, yeah, and primarily those patients so there's certain deletions like MIND17P that does not respond at all to traditional chemotherapy, and so prior to the availability of ibrutinib either on trial or commercially, that was one of the only options that patients had to get some kind of a treatment. So you'll see some people that are, that were diagnosed a long time ago that continue to stay on Revlimid and it controls it. But to the best of my knowledge, nobody is being put on it with CLL, anywhere along their course of therapy now.
I have a feeling that that's going to change dramatically as far as Celgene, of course, is the manufacturer of Revlimid, and they just merged with, I think, with Bristol Myers Squibb, if I'm not mistaken. Yes. Was that?
You're correct.
Yeah, and so that just happened. I think it just got approved at the end of this last year, and I have a feeling that some things are going to change, partly because there was a few cases that have come out in the past, like year and a half, 2 years, where they've made it generic overseas, but not in the United States. And and again, and I'm sure Thomas, you're probably very aware of this, but Revlimid, I'm on a 10 milligram course, and when I was actually prior to my bone marrow transplant, I was on 25 milligrams, and at 10 milligrams every 3 weeks, they're listing the round cost for 3 weeks, so 21 pills, as $15,900 for 21 pills.
How much?
And 15,900.
Wow.
Yeah, for 21 pills every round, and I do this all the time. So I've been doing this since January of 2016 is on this particular maintenance course, And so there was an article that came out a couple of years ago. I don't know if some of y'all saw this, but so a myeloma patient, well, actually was an oncologist in California. I don't know where in California. He somehow helped one of his patients get a 90-day supply of Revlimid from India, I believe, for $90. $90 for the same drug. So, and that's ridiculous. I mean, again, 90 days versus, I mean, that's just not even, it's crazy. And so what I have a feeling what's going to happen, this is my guess, is that what's going to happen is that the pharmaceutical companies that are looking for alternative, that are trying to move their myeloma drug into a first tier drug, they're going to come up with also less expensive options. The great thing about Revlimid is that it's in a pill form. It's the granddaddy. That I know that it's been effective at keeping things stable for a lot of people. However, there are others that are coming out. What do they call them, Thomas? Biologicals or something? Is that right?
Oh, biosimilars.
Biosimilars, right. So it's not as harsh as what we think of when we think of chemotherapy, right? Yeah. So it's good in that sense, I suppose. But again, this has been around for a long time. I believe the concept of the drug actually started, if I understand it right, in the late 60s. It was used for a different purpose. And I'm sure I don't know what the purpose was, making birth defects or something. I don't know what its cause was. Something
It's
like that.
related to thalidomide, and
That's what I'm thinking of, isn't it?
yeah, and thalidomide, was when I was a kid back in the 60s,
Oh,
it was like on the cover of every issue of the Inquirer, these children born with these gross birth defects. So yeah.
I've met a couple of thalidomide kids. Yeah.
Yeah.
So but that won't do anything to the person taking it, just to their, I mean, it's doing something to your genetics.
They are actually very, one of the things with Revlimid is that every time that every single time, so every 4 weeks, I have to either, if I don't get to the internet first, they ask me on the phone about making sure that I am not procreating or donating to a blood bank or a sperm bank. That if I am having sex with a woman who has her womb, that I'm using a condom at every time. Oh yeah, they know way more about me than a lot of people do.
And now we all do.
Kenny, they're required. Kenny, they're required. Yep, but they are required to ask those questions.
Oh, I know.
Before the drug company agrees, because they ask the same questions. So
sure,
yeah,
no, I know. I'm being snarky, but that's just.
No, it's just
I'm smarmy.
It's a little awkward sometimes. Yeah.
I'm not shy.
So Tom, do they say that about other things too, like ibrutinib and all that? Because I do know of at least one person who has
Is mommy okay?
procreated and had a baby while taking ibrutinib.
Okay. I'll be in a little bit worried. Okay.
So I'm not aware of any of the oral CLL drugs having any kind of a warning about, any kind of reproduction issues.
Did you say they do or they don't?
Not, so I mean, I've done some pretty good research on ibrutinib, acalabrutinib, venetoclax, and idelalisib, and written up some, articles for the CLL Society on those, and I didn't find any reference to anything that said that, you had to be concerned about any reproductive issues.
No one mentioned, it's interesting in that no one did mention that to me. It didn't dawn on me until I was on it for maybe, I don't know, 9 months, 10 months. And then it dawned on me, I'm like, wait, did they tell me? And I, maybe I blanked it out or don't remember, which could have happened at the time, but they never did that I had recalled. Well, that's a good thing for everyone who is still having babies.
Yeah.
On it, I do wonder. Kind of worries me.
Let's clarify. I'm done. Did I mention 3? I'm good.
I figured you were good on that one.
I'm done. I am so done. Yep. Absolutely.
So as far as stem cell so both Kenny, you and Richard both had stem cell transplants?
Yes.
You
I
know,
did. Yep,
Lots of fun. Everybody should have one.
yep, yep. And actually, I was, aside from preparing us for the Nova, I mean, for the virus stay-at-home stuff that we're all dealing with, the prep that I got from the hospital was really quite amazing. So one of the things it does is to destroy entirely your immune system. And so, we had our car cleaned professionally and sterilized. We had our home steamed, not steamed, but clearly cleaned up. And after, I think I was in the hospital for 18 days or so, and
Pretty good.
when I got home, I felt like you may not remember the movie The Boy in the Bubble. But it was pretty clear. It was nobody in the house, and or if they did, they came with what we've come to know today to be pretty standard, with masks and gloves and foot things. And so if they were coming in, I was making sure that they weren't bringing anything close to what I happened. But I thought it was pretty easy. I mean, it was took out blood one day, gave me some nasty drugs after that, and put it back in the next day, and hung around the hospital for 18 days or so.
You did better than I did, I think. So I think I was in the hospital for almost a little over 4.5 weeks.
Oh my heavens, yeah.
Well,
Yep.
and actually I was, so they did release me, and it was mostly because I whined a lot. They did actually release me right at 3 weeks the first time, because I was complaining a bunch, and I said, I'm ready to go. Let's get out of here. I'm ready to go. And so I was going to stay at a hotel near near where I had the transplant. It was in Emory in Atlanta. And I was supposed to, and so my wife's uncle was there, and my mother was there, and they took me in. And as Stan was checking into the hotel, I passed out right in the lobby. Spiked a fever 105, and I felt like they just revoked my parole. They sit me around.
Yeah, they did.
Yeah. So, and they put me in for a couple more weeks because then they had to make sure that I wasn't going to have it, which apparently is pretty common after that. There's some sort of rebound thing going that happens. And apparently it's pretty common, but yeah, it got me pretty good. Although I have to say, I thought the process of the harvesting was pretty brutal too.
Did you really?
Yeah. So because they wanted 12 million, was it 12 million? Yeah, because they wanted 4 million per transplant or something like that, and so they wanted to have enough to do 3 total. So they wanted 12, and so the first day they got like 5, and they're going, "Sweet, this is gonna be cake." They said, "Yeah, we might be done with this tomorrow." Yeah, well, that was on a Monday morning. They didn't get everything until Thursday, so and I had to do that like 8 hours a day, seriously, every day.
Yeah.
Oh, that was exhausting.
Yeah.
It is. And you can't do anything. You have to just sit there. There's nothing you're gonna do. Can't move. Can't get up. Can't nothing.
I have a question.
And especially if you have a technician who was thoroughly unpleasant, no sense of humor.
Oh yeah. Mine were sweet. They was real sweet.
But
let me ask you something, Richard and Kenny. So with CLL, for some people it has a really tremendous psychological impact, and for other people it doesn't seem to. So in your community, it would sound to me that, I mean, the constant reminder of pain that you must have, that it must be emotionally extremely trying. Is that the case?
I can't speak for Richard.
Yeah, Jay, it's, I should just, to be fair to you, I'm a psychologist by training, so
Dun, dun, dun.
and experience, but I just wanted to just in fairness to share that with you. What my experience both personally and professionally would tell me is that there's wide variation here. That some of us are likely to behave in a certain way based upon what life experiences have been for us, based upon our imaginations. And I had no idea what a stem cell transplant was. Jesus, I mean, when you just to hear the
Right.
words, you think, "Good God Almighty, what the hell is this?" So arriving at the hospital and then being hooked up to the machine, which drained, I forget now the number of red blood cells that they took out of me. I mean, that part was pretty easy. Having to go back and get some injections afterwards was also, it was just another injection. So, by and large, the piece that I had the biggest struggle with was certainly spending 18 days in the hospital, feeling pretty good, having a ton of visitors, and a whole bunch of really very easy to get along with nursing staff at the hospital that I was at, and it was okay. I missed my wife. She was working, but she was down from Maine into Boston and what have you. But there was some anxiety that I had with it, and certainly in coming home and being this boy in the bubble and knowing what that meant, and being concerned about picking up viruses. I was there in December, so the flu was floating around in the Boston area, in the Maine area, for sure. So we were, very concerned about that. So there was some anxiety on my part, and I certainly see that on the part of others. It just depends.
And what
Any
about
of
Kenny? Were you? First, I apologize, but how long now have you had ML?
How long have I had it? So I was diagnosed. Well, I went in for my first something, whatever I thought it was, in October of 2014. But they didn't officially tell me until January of 2015.
Okay.
And then I had my bone marrow transplant in August of 2015.
See,
So
like with our disease, one of the downsides is that a lot of times people seem to be I mean, it's a good thing in a way, but they seem to be asymptomatic for a long time. So that when I was diagnosed, here's this doctor coming out and laughing it up and saying, "Congratulations, you have," and he literally said, and Michelle will know, and Tom will know what he said. "Congratulations, you have the good cancer."
oh,
And so,
congratulations, L'Chaim.
and I was like saying, "Hey, terrific! How about the good bubonic plague?"
Yeah.
And like, so I looked at the doctor with a straight face, and I said, "Really, you think it's so good? Why don't we trade? I'll give it to you." So he kind of looked at me and I said, "Do you really think you should say the word good right before you say cancer? Because where I'm sitting, it ain't so good, And so this is a very common thing discussed among our group of leukemia lymphoma patients.
Sure.
They're always being told, "Well, you got it pretty good. Don't complain," and it's a little patronizing. So I'm curious, when a doctor looks at you, are they downplaying your disease, or are they telling you, "Well, you got this, but it isn't as bad as it could be," or is it? How does that compare to CLL?
Well, I don't. I mean, I don't know. That's tough to say because it probably depends on my attitude at the time. And I think most of the time I try to lead in, and sure, some of it is maybe um, forced some days, depending on what day it is. Um, but I think my attitude is to walk in there with a not so much that I'm going to beat this thing, but that it's a thing. It's a thing that I have to overcome. It's an obstacle that I have, and I have it today. Today, this is my obstacle, and so I want to diminish. I look at it as something that fit into my calendar. Today, I have so many things to do. I need to make the coffee. I need to go for a run. I need to make eggs. Oh, I need to treat my multiple myeloma, and then I need to go to work. I need to pick up the kids. I need to, go to a soccer game. And so it's part of what it is that I work into my day. So, and the reason I say all that is because the feedback that I get from my doctor, whether it's my local oncologist or my myeloma specialist in Atlanta, um, largely my response um, is sort of how, or is really, I don't want to rephrase that. His statement to me, or his challenges to me, his analysis of what's going on in my world from his point of view, based on blood and biopsies and so forth, is really interpreted by me depending on how I want to receive it. The way I see it is I feel like I can choose how I take that. And don't get me wrong, I get it. It's really, am I allowed to cuss in here? It's shitty.
Sure.
It's just really, it's
As long
really
as
shitty.
Michelle says okay.
Okay, well, Michelle, if you say it's okay to cuss,
From
then
North Carolina, and you're cussing. Good God.
oh, I said I was in Asheville. We're different up here.
Oh, that's right. That's right. That's right. That's right.
No. Well, be
Yeah.
careful. The ropes are off. The
The
chains are off.
sheriff, yeah, the sheriff is still looking for me. So,
That's right. No. He's dropping F-bombs too. So I mean, I know.
Jay, the thing I would say, the two things. When I was told, I wrote an article. It was published in Cure magazine, and in there, tell your story. If you want to go look at it, you can look at it. But my general practitioner, family physician, told my wife and I over the goddamn telephone, which he insisted that we put on speaker. So I came home from work. He calls me and says, "Can you put your phone on speaker? Because I have something to tell you." And it's not good news. So my wife is a PhD nurse, and she looked at me with an, "Oh my God." So we put it on, and he told me that that I had some minor surgeries before, and they did they did a test on the material that they took out, and that I had tested positive for multiple myeloma. And I'm going to tell you, the level of anger, of tears, of devastation that I felt at that moment with my wife, and we're holding on to one another, bawling our heads out, screaming and saying, "My God, what are we going to tell the children? What am I going to tell the people at work? I had the best job in my life, and I'm 69 years old, the very best professional job I had ever had." And I knew, because of the extraordinary pain that I was in, and I was in extraordinary pain, and I take medication to the point of 225 micrograms of fentanyl which is a very large dose of fentanyl, to control the pain in my body, that I was very angry. And I still have times when damn it, it's 5.5 years later, and I still have a day or two every so often when that anger comes out, but I feel much more confident now, much more, my wife and I we made the decision that we were going to go forward and be adults and work with our children and pray to God that we be the kind of parents and adults and professionals that we were, neighbors, and that's honestly worked for me. So
There's a lot of doctors, unfortunately, out there that just have no ability to communicate with their patients, and
for sure,
they actually cause more harm than they do good. And I'm hoping, Richard, that was the last encounter that you had with that doctor, and you moved on quickly.
I was, he was not the oncologist, Tom, but I did say to the oncologist the first time we met her, I said, look, my biggest question for you is, can you be honest with me? I didn't want any BS, but can you tell me, if I'm close, if this is, are you giving me the 30-day notice? Do you have the ability to be that level of honest and say goodbye to me, so I can turn around and say goodbye to my family in an appropriate way when that time comes, and I believe it will come.
Mm-hmm.
Just not for a long time. But and she's okay, but not with the, I think I make her nervous because of my own background and what have you. But the fellow I see in Boston as a sort of backup oncologist is much better. And I knew it was going to be better because he hugs me every time that he sees me. And I don't know, it just feels good, just to have that sense of human to human compassion that Jacob Laubach provides is just extraordinary. Anyway, so I don't know if that makes sense to you, Jay, but are you asking that kind of a question?
It makes a lot of sense.
Yeah, I was told, as Jay had said, the same way. I had no clue. I had no clue what I was being tested for. I just knew they took a lot of blood and I had no time for it. Kenny, like you were saying, it was just like, really? I have to go have blood tests? I mean, I didn't even know why I was being sent to I walked in and it was the Sylvester Cancer Center. I lived in Miami at the time, and I'm like, well, maybe they don't have enough space in the rest of the hospital, and that just happens to be where I'm going. I honestly had no clue. I was too busy to worry about it, and I had kept putting it off to fit in my schedules. And they called and told me 2 weeks after all the tests were great. They called me a few weeks later and said the doctor wants to see you, and I was just like, why? I'm fine. I'm like, okay, whatever. And I went. He said this is what Jay said. He said, well, I want to tell you, you have the best cancer that you can have. And I was too dumbfounded because I had no clue that was even in question to say anything back.
Why can't you call it the fabulous cancer? At least, right? Call it the fabulous cancer. Wouldn't that be better than the good cancer? You're like a movie star then. Sorry. I couldn't read it.
So I was just sitting there. I'm like, huh? What did you? He said, yeah, you have. He like rattled off. I've never heard of chronic lymphocytic leukemia. I was like, can you spell that? Can you say that again? Slowly? It's like what? You have my attention now. I'm like, did I hear leukemia in there? And so
my doctor couldn't even pronounce it. He said, you have chronic blah 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 blah. And I said, what? He literally could not pronounce lymphocytic. He said lymphocyte. And I said, come on, doc, what the heck is, you know something? I don't know about you guys, but like everybody else, I Googled for about 3 weeks before I got my whatchamacallit. I knew what I had. I was just, and kind of, like we're kind of like hoping that that's it because because you look at all the other types of things you could have and you say, okay, well, maybe I can handle this, But did you know? I knew before I went I had it. Really? Did you, Michelle?
No, because that appointment was with a hematologist who was also an oncologist. But again, I honestly, I was in the cruise industry. I was the head of communications for Royal Caribbean, who owns 8 cruise lines. And I was the head of the communications board for the Cruise Line International Association, which basically meant for the association, I was in charge of all the communications, basically if anything bad happened. And a ship had just gone down, the Costa Concordia, and that was owned by Carnival. So it wasn't one of our ships, but it still affected the industry. And honestly, it's like I was not sleeping. That was, I had interviews here and there with all these crazy journalists from all over the world. And it was just, I do not have time for this. And I didn't pay attention that it was, sure I knew it was a hematologist and I should have known because probably, I don't know, a million years ago, I dated a hematologist oncologist. You'd think that I would know that they're related, but I didn't have time to think about it. And I honestly, I was in great health, and always had been. And this doctor never mentioned in the first meeting anything what it could be. So I honestly am like, I was really taken by surprise and shocked. Then I went on the internet and never should have, because at that time, nothing had caught up. Patient Power was pretty new and there was hardly anything by them. It took me a while to find them because they probably didn't have anyone doing SEO. So yeah, I was going to be dead in 5 to 8 years from what I saw on the internet. Or I should get a sauna, a red light sauna, pull out all my if I had root canals or caps or fillings. I saw crazy stuff online of what to do. I don't know if any of you had that happen when you looked up things.
Get rid of all those amalgam fillings in your mouth. That was one of the things. So, and I think that's one of the things that Jay and I struggle with is we see a lot of stuff on this online forum, that somebody reads an article in, Good Housekeeping magazine and they're quoting it to these, at this point we're knocking on the door. How many we got between the two groups? We probably have over 1,000 CLL patients, and getting people to understand that you have to read reliable information, is really, really, really difficult. And it's a struggle. And and I think for me, I try to come across as, yes, I'm a healthcare professional who happens to have CLL, but I don't want to come across as being something that know-it-all either, and so, but there's just sometimes where it's like people make out and out, false statements, and you just can't allow that to keep being passed from one CLL patient to another, and so sometimes I will get a little, hopefully not snarky, but, I want to make the point that, you have to be really, careful of what you're saying. And
you're very good, Tom. You're very good at, like, when you get mad at somebody, it's like you're the nicest mad guy I've ever seen. When I get mad, I'm horrible. It's like I'll be nice for about 5 minutes, and then if the person doesn't get it after being told nicely 10 times, then I go crazy. But Tom, there's 3,000 people on my forum, and on Jeff Polota's forum, 500.
He was supposed to join us tonight, by the way.
That's 10,000 between those.
Yeah, that's
10,000. Yeah. And it's interesting. We have, I think on both groups, we have a lot of women that are in it because their spouse has CLL, and the male doesn't want the information. Typical male, we don't want to go to the doctor. We don't want, we don't want to know about our condition, and so, and so that's a kind of an interesting dynamic that you see play out too. So.
Richard was trying to get us to talk about emotions last week.
Yeah, it was with some struggles. I will confess, but
Yeah, the thing is, Michelle and I don't really have any emotions, and that's the problem.
yeah, Kenny, I made that determination, and if I could prescribe medication, I talked to Tom, and we'd get you some things that would help in that department.
I have another question for you guys. So with ML, are there ever, like, since there are different types of ML, just like with CLL, Tom, and correct me if I'm wrong, I think there's over 70 subsets of CLL. That's what I've read. Whether, I can't swear to it, but so does there ever come a time when you are totally misdiagnosed with the type that you have? Because with me, with CLL, first I saw a general oncologist and she totally got it wrong. She did the testing, but I was told I had a much worse type of CLL than I actually had. I was told I was unmutated, and I was told that I had this one deletion, this ZAP70, this one bad thing, and I didn't have it. So I'm just curious. And then I went to see a CLL specialist. So are there ML specialists that only do ML? Anybody?
Well, I don't know that they're. So yes, there are myeloma specialists. I mean, there are extreme myeloma specialists. People, and I go see one of the top dogs in the country, and I actually have 3 of them on my board with Throwing Bones right now. So, and they're not necessarily. Well, one of them is a myeloma specialist. The other 2 do deal with myeloma a lot, but they also deal with other blood cancers. Their focus is more on the bone marrow transplant side of things. Both the autologous and the, it's going on my head, Richard just said, on auto and allogenic transplant. Anyways, so they focus on
most people with ML wind up having to have a BMT.
That's a pretty common first step if you are eligible for it. You have to physically, and that's another reason why we're promoting this sort of thing, because in order to get to some of the treatments for a lot of different blood cancers, they're pretty brutal. And a bone marrow transplant for most people is pretty rough. And there's a lot of reasons that you are not eligible. In fact, I think there's a really harsh review of having a bone marrow transplant if you're over the age of 70. Number one. I think that's one of the markers, and the other one is having, our American failings of, diabetes or prediabetes, obesity, high blood pressure, hypertension, cardiac disease. So those are all markers for being ineligible for a bone marrow transplant. But yes, so in terms, Thomas mentioned earlier about MRD, and so one of the things that they believe actually work well in accomplishing that, and that's sort of the common things, is to get a maximum response. Is that, and so they look at it, at least the way it was explained to me, as they're trying to get below 0, where it's sort of a negative response, almost. So you have a long time to work up a better solution. Is basically what it is. They're trying to get more
Are there
time.
people with ML that will have a long-term survival? Let's say they get it at age 70 and they live to be 100.
I don't hear about. Although I mean, it's certainly possible. My mother actually is a retired physician, and she had some myeloma patients. She's told me, although I didn't know this later because I'd never heard of myeloma until I got it. But anyway, she said that she had patients who were over the age of 70 when they were diagnosed, or even actually in their 60s. She said it was very often, even back then, so this would have been in the late 90s, that probably more often than not, her patients at least, she says, I don't know if it's indicative of the whole pool, but her patients usually died of something else, not myeloma.
That's pretty common with CLL as well.
It depends, and again, it depends on how aggressive it was to begin with. So there, Yeah, there's certainly plenty of it. And again, myeloma is turning into I won't say it's chronic yet, certainly, but it's getting to the point where there are so many options, so many treatment options that weren't here a decade ago. I mean, so it's that fresh, that there are so many options that people can roll through them. And now with the onslaught of CAR T being such a big thing, and that's such an enormous buzz phrase, that's a game changer for so many people, so many patients, so many doctors. In fact, the last time I talked to Dr. Loniel, I'm sorry, it wasn't Loniel. I actually did a tour of Janssen Pharmaceuticals up in their facilities north of Philadelphia. And so talking to some of the doctors up there, and they gave like a little presentation. There's about 4 or 5 of us, and they gave a little presentation, and they said that we feel confident actually within the past few years that we've cured some of these cancers. We just don't know how, because because what they're trying to do now is find those, because there've been so few, is finding what those commonalities are. What are the magic things, and people are different. I mean, it boils down to genetics a lot of times, and it's finding that magic, connection. Yeah. And so, yeah. Sorry. Go ahead.
Well, I wasn't sure we're going to run out of time here, and I wanted to correct an error that I spoke earlier about sort of something similar to what you were saying in terms of the number of clinical trials that are going on. And I think I misspoke when I said there were 100 when I was diagnosed in 2014. That was not correct. There were 10.
Oh, okay.
And today there are about 100. So I think I said 100 and 1,000. And that's just an exaggeration. And I do apologize. It was 10. And as of last year, there were 100 approved, what do you call it's going on throughout the country. So I wanted to.
Specifically for myeloma?
For myeloma, yes. Yeah, so I wanted to make sure that.
Sure. Well, thank you.
Yeah.
Michelle, I think you were trying to, oh gosh, he's back.
He's
All right,
back. Don't say anything.
Act natural.
You don't have to.
Jane and Tom, you've been really great participants here, and I hope that you can join us again, because it is very interesting to hear some of the similarities between all of us here. I mean, we have just tonight 2 different blood cancers, so that makes it a bit easier and more narrow focused that we can at least find some of our commonalities, but it seems high cost of drugs. I was writing them down, indefinite therapies versus they're now trying to have defined term. Is it, Tom? Is that the
defined duration or defined interval? Yeah.
No cures. Bone marrow is. I would love to know, Jay, sometime, not today, but another time, if you have any diet tricks to help build bone marrow and bone, because that seems to be a common thing. And there's different versions of our cancers here. Stem cell transplants and CAR T, they're like the thing people are trying to do, and that we're all high risk right now. But I'm sure there are some other commonalities that we have that we spoke of that perhaps I did not catch here. Anyway, I'm talking about feelings.
Yeah.
All right, Michelle.
Be able to.
So one of the interesting things that, that I've encountered since 2008, I have done interim leadership in hospital pharmacies. And so I finished that up in August of last year. I had done 17 different hospitals. So my last 2 assignments were at 2 major comprehensive cancer centers. So for 22 months, I was at Moffitt here in Tampa, and then I was at Roswell Park in Buffalo. And so, a lot of people don't know that today in pharmacy, we have residency programs to, give postgraduate education to our pharmacists, just like physicians do. And so We had residents at both of those locations, but at Moffett, we had 4 residents, one that was a general postgraduate year 1 resident, and then 3 postgraduate year 2 residents. And those are pharmacists that want to specialize in oncology for their future. And they would present on a weekly basis for the entire pharmacy staff continuing education classes. And what was really striking to me was the first time I heard them start talking about the same deletions that we see in CLL being present in other blood cancers, and so it was, and it's like, makes me think like, okay, I'm a 17p deletion, but there are other blood cancers that patients have 17p deletion. What triggers that I'm going to get CLL and somebody else is going to get some other, but we have the same deletion? So, I think that there's, a lot of commonality in the blood cancers. I think I mentioned earlier, and if I didn't, all the drugs that pretty much are, being approved for CLL, very often they're requesting that they be approved for mantle cell lymphoma at the same time. Sometimes I know with venetoclax, they were approved, they were submitted on the same day, the applications. And then I think it came out for MCL like a month or 2 before the CLL approval. So there's got to be some real similarities between those two, that there's a lot of commonality in the drugs that are being used. So yeah, I think there's enough commonality. I don't know how we get people interested in learning about the other blood cancers, but I think that it's encouraging for all of us to see so much of the research that's going on and so much of the progress that's been made. And, it's probably been in the last decade that we've really seen. If you look at, we're staged with a 4-stage system, and that causes a lot of confusion for CLL patients, because it's not like a solid tumor cancer where a stage 4 is essentially metastatic disease that's spread all over your body. It's just how involved is your CLL in your body, and what organ systems are involved. But if you look at me, I had gotten up to a stage 3 on a possible stage 4 before I started treatment. And if you looked at that Ray table when I first got diagnosed, and it still says the same thing today, with a 17p deletion, my life expectancy was an average of 3.5 years from the time of diagnosis. And here I am, 4.5 years, essentially in remission with a white blood cell count of like 4. So, yeah.
That's
So
from
I want to jump in on a whole bunch of stuff here, but I'll keep it very short. The first is, of course, as Tom well knows, this concept of basket approvals for cancer drugs is now something that has really taken off in solid tumor cancers. And we have them now, especially with the immunodrugs. So it wouldn't surprise me at all if we'll start to see the same thing. The second thing I want to ask you is, whilst you were at Roswell Park, did you ever run across a cancer genetics professor called Bill Burhans?
I don't think so.
You don't? So
No.
Bill was on our board. We lost him in October to prostate cancer. He had a BRCA2 mutation, and it was very aggressive, and he became a very dear friend of mine. Went to Buffalo a few times, went up to his lab, went into his lab and saw his lab. But what was most amazing was that he'd been working on PARP inhibitors long before they were implemented, and he predicted the use, and then he finished up being on a PARP inhibitor, presenting it to his tumor board, and getting onto that PARP inhibitor.
Yeah.
What I want to say to you guys is your conversation has been brilliant. For somebody who doesn't know too much about blood cancers and is listening from the outside, it's just been an excellent hour and a half, and it's flown by. and I congratulate you because the conversation flowed perfectly, and it was very good. Now, of course, it'd be nice if we can bring in some more people. It would also be nice, and we're very happy to host these virtual support groups for your specific diseases. You know, we could do one just for multiple myeloma. We could do one for
But Richard and I can just sit around and talk amongst ourselves.
right. That's right. What I want to see, and you didn't
As long as
mention,
he doesn't bring his gun with him, we're all set. You know, he's
I don't know.
North Carolina.
Again, Asheville's different. We don't do that up here.
Oh, that's right. I'm sorry. I'm thinking Charlotte. I'm sorry.
Yeah.
Listen,
Yeah.
Richard, what you want to make sure is he doesn't bring his running shoes with him and schlep you along. Because
Yeah, well, I could use a little kick in the.
yeah, you know, and you're in the wrong place because we'll give you that kick,
Yeah.
Kenny and I.
I'll do it.
There's been, and it's interesting to me that there have been common threads. I mean, this issue about exercise, it's huge. It's huge in the cancer communities I deal with. The issue about, this being the good cancer. We hear that all the time with prostate cancer, and it drives the guys nuts because there's only a minority who have cancer that needs to be treated very seriously, but they're there. Like Bill, God rest his soul, who we lost in a matter of 2 or 3 years. But there are common threads. So the next meeting that we have for you, for this group, will be the second Wednesday in May, which is the 13th. If any of you have ideas how you want to improve it, change it, feel free to reach out to me. Please let your groups know, because you have big followings. And I think you can appreciate how different this experience is than being on a written forum and exchanging written notes with each other. I mean, this is a real conversation. So the last thing I wanted to mention is we do have some other groups that might be of interest. We have a Speaking Freely group, which will be on the 16th, which is to deal with everything other than treatment. So it's like the group for Dr. Farmer there. And we don't use it's for men only, and we don't use the E word, otherwise we'd frighten everybody off. But it is, it is to discuss the emotions around cancer and what have you. And again, you're very welcome. We have a caregivers group for any caregiver dealing with looking after anybody with advanced cancer. And we meet twice a month. And again, any caregivers for blood cancers are very, very welcome, male or female. I think those are the main points that I wanted to make. And I really, do sign up on our website. I have Tom's email. I found that. I don't have Jay's, but just go on our website, ancan.org, and sign yourself up. So we'll send you a reminder for the blood cancer, maybe for Speaking Freely. And that's about it. And you guys did great. You did great.
Thank you.
Thank you.
Well, I'm gonna go read some Pippi Longstocking now. So
Okay. Okay. All right.
so it was lovely meeting you folks, and hopefully we'll get to do this again real soon.
Amen.
All right. Talk to you all soon. Good night.
So,
Good night,
Everybody.
everybody. See you next month, if not before. Bye-bye.
Paul,
Bye now.
Jay,
You're
thank you.
welcome. Take care. Thanks for having me.
Bye-bye.
Bye-bye.
Bye.
This conference will now